I'm going to talk a little bit about the program that Kitty mentioned. And again, I'd like to thank the organizers for including me and giving us this opportunity to begin to share what we're trying to do. Our program is called the Obstetric and Pediatric Pharmacology Branch, and there are a series of threads that have come together within the program, and I've tried to list them in chronological order because it's evolved over time. About 10 years ago, a group of pediatricians approached the Institute and told the director that there was no infrastructure for conducting clinical studies in pediatrics. And so to remedy that infrastructure gap, a pediatric pharmacology research network was created. Actually, the network, like a lot of academic activities, also drove legislation. And within the United States, a series of legislative activities have focused on improving the information that's available for treating children, ultimately resulting in 2002 in our U.S. Congress passing a law called the Best Pharmaceuticals for Children's Act. And that actually creates within the National Institutes of Health a small entity that is essentially a pediatric drug company. This entity, us actually, is intended to look at drugs used in children, to understand what's known about dosing, safety, and efficacy based on clinical studies, and where there are gaps between how the drug is used and what's known about the drug. We're authorized to conduct those studies and ultimately change the label of the drug, or at least improve therapeutic use of that drug. In 2004, the Institute, responding to similar questions or queries or concerns from obstetrics, created an obstetrical pharmacology research network, much like the pediatric network. But in this network, in the obstetrical pharmacology network, the focus is less on creating an infrastructure and more on trying to build the science approaches to understanding dosing, safety, and efficacy of drugs in pregnancy. And I'll talk briefly about some of the programs there. And then this year, just actually this month, we've created two institutional training programs that we hope will help us build a feedback loop into how we think about safety and efficacy. And these training programs deal with reproductive, perinatal, and pediatric epidemiology. And the idea here is to help us understand what's the health status, what are the therapeutic approaches that can be used, and then if those therapeutic approaches are used, how does that alter the health status of our communities? And this actually comes from a large planning process that the United States has been involved in for about 30 years, called the Healthy People Process. The idea is to set goals, health goals, for the nation and ask, how do we work to achieve those goals? And the two overarching goals for Healthy People 2010 were increase quality and years of healthy life and eliminate health disparities. And the idea here is two goals that we can all easily understand and work toward. And from our perspective at the Child Health Institute, we believe that both of these goals are strongly influenced by health prior to conception, throughout pregnancy, and childhood. And so that's what drives our thinking in terms of opportunities or activities within our program. And this is the way that that the process has been described graphically for Healthy People 2010. We have goals, we have objectives, and then for many of you who are familiar with much of the work done in terms of determinants of health that's come from colleagues here in public health in Canada, you'll recognize that this is the kind of structure that we use to try to integrate a range of factors or activities to help us understand, ultimately, health status and improve that health status. So we're using what we've called roughly a systems and population approach. What are the systems biologies that we need to understand to improve health, and what roles might pharmacology play within that context? So what's the problem with medications in pregnancy? Well, we know that there's nothing special about pregnancy in the sense of acute or chronic diseases. They continue to the same extent that they occur in women of reproductive age. We have very limited information on pharmacokinetics and pharmacodynamics of drugs in pregnancy, and very little additional information about how the many changes that occur across the course of pregnancy influence those. In obstetrics, much like we find in pediatrics, clinicians are required to make therapeutic choices, but they're required to make therapeutic choices in a context in which there's no good data about dosing, safety, and efficacy. So every patient that's treated, in many cases, ends up being an experiment of one. And so what we're trying to do is reorient that approach so that we can build a better science base for pregnancy therapeutics. And this is just to remind us that diseases across the course of pregnancy, hypertension, diabetes, depression, just as examples, not only do they complicate the health of the mom, but they also complicate the health of the pregnancy itself. And so our goal is to try to put these studies in place, and we have to understand, and we encounter this tension, which is that you can't do studies in pregnant women. That's actually not correct, but that's the tension that we need to deal with in a clinical and public health context. I can tell you that one of the groups that has the strongest opposition to improving clinical therapeutics in pediatrics has argued that it's immoral to study drugs in children, and has argued that in the U.S. Congress. And our response is that if it's immoral to study them, how can we ever know that we're treating them appropriately? But those are the tensions that we and others will encounter. Let's start by taking a look at sex differences in therapeutics. They've actually been noted in animal studies since the 1930s. However, in the U.S. before 1993, women were actually excluded from most clinical trials. And they were excluded for the obvious reasons. If you include women, that will mess up the clean, narrow efficacy focuses that we're interested in trying to understand. And of course, the therapeutic argument against that is, if the efficacy is so small that you need an incredibly homogeneous group to see it, it's probably not going to be a useful drug. And it seems to me that from a therapeutic perspective, we know that when we use drugs, we're treating an incredibly heterogeneous group of people. So we would hope that the studies that demonstrate efficacy actually demonstrate efficacy in the kind of heterogeneous group that we're going to be using the drugs in practice. And of course, the other is potential for pregnancy. In 2001, our government accounting unit, called the General Accounting Office, or more currently the General Accountability Office, evaluated drugs withdrawn from the U.S. market over the period January of 97 through December of 2000. And of the 10 drugs that were withdrawn from the market during this period, 8 of them were withdrawn because they had more severe toxicity in women than they did in men. So here's an example where not understanding how the drug worked and what it did in men and women led to ultimately a therapeutic failure in the sense that the drugs needed to be taken off of the market. Well, in our Food and Drug Administration's Adverse Events Reporting System, called AIRS, Adverse Events Reporting System, it's been observed that women report more adverse reaction to drugs than men do. And if that's the case, there are several reasons that need to be explored that might help us understand why that is. One is that women may be overdosed as a result of pharmacokinetic differences. Women generally take more medications than men, and typically as the number of medications consumed increases, the likelihood of drug interactions and adverse events increases. It's an artifact, or that there are really pharmacokinetic and pharmacodynamic differences that result in women responding to drugs more differently than men do. Well, we do know that there are pharmacokinetic characteristics or pharmacokinetic parameters that are different in men and women. The volumes of distribution for water and lipid-soluble drugs are different in women and men. The water-soluble drugs have smaller and the lipid-soluble drugs larger, typically volumes of distribution. Hepatic metabolism is different, and there are differences in cytochrome P450s and emerging knowledge about differences in drug transporters. And while there are some pharmacokinetic differences, that only partially helps us understand the difference between men and women. Women tend to take more medications than men, and they begin to use them earlier, typically those that interact with the reproductive system. But it's unclear, at least in the U.S. adverse events reporting system, what proportion are due to drug interactions. As an aside, I've asked the FDA to look at the adverse event reporting system to see if they can tell us how pregnancy alters reports of adverse events. And I'm sad to have to tell you that there's no data. We don't know what pregnancy does to adverse events reporting or the occurrence of maternal adverse events in the United States. And one of our investigators in the network is beginning to try to sort that data out. To the extent that the Canadian Drugs Health Canada has systems or data sets that might help us explore that issue, that's an area where I think it would be really, really interesting to begin to try to develop cross-country collaborations. An important question, not looked at all. It turns out that women report adverse reactions more frequently than men. But the thing that I think is intriguing is in the United States, the adverse events reported by women tend to be more life-threatening than the adverse events reported by men. So that they're more severe, the reports from women, than they are from men. And here are just some of the serious adverse events that are reported by women more frequently than men. The first two go together. They deal with repolarization of the heart, and the QT interval is androgen influenced, and so in women the QT intervals are longer than they are in men. And many drugs, and in fact of the 10 drugs that were withdrawn, the 8 that had more toxicity in women, much of the toxicity was expressed in terms of cardiovascular toxicity. I just commented on that. The other thing that I think is intriguing in our adverse events reporting system is that acute liver failure occurs about 2,000 times a year in the United States. More than half of them are thought to be due to medications and reactions to the medications. 3/4 of the acute liver failure in the U.S. that's reported to the FDA occurs in women. And the fatality rate is usually quite high. And so the question for us as well is, why is that? I mean, what's going on here that produces this? And again, here I think is an example where we need multiple kinds of collaboration across countries. I'm going to comment briefly about some of the pharmacokinetic factors that are different in men and women. Gut transit times are different, generally shorter in women than men, but they do vary with progesterone. Lung absorption is proportional to respiratory rate. The thing that's intriguing, and I don't know how it stands here, but the US FDA has recently approved an inhaled insulin. And we have no understanding right now how sex differences will influence the efficacy of the inhaled insulin, nor do we have any understanding of how the pulmonary changes that occur across the course of pregnancy will influence the use of that inhaled drug. Protein binding and body composition changes, and we're well aware of that. Drug transporters, the P-glycoprotein generally has greater activity in men than women, although the role in transport and metabolism, I think, needs to be looked at in greater detail. So the sex differences that we see in pharmacokinetics and pharmacodynamics should serve as a stimulus for us to try to begin to understand how those sex differences are further magnified or altered across the course of pregnancy. And I'm going to give you just one example, the antiretrovirals. We know that it's important to preserve efficacy of antiretrovirals across the course of pregnancy, efficacy in the sense of treating the mom and preventing HIV infection in children, to minimize viral levels in the mother. So at delivery, plasma HIV levels are associated with perinatal transmission. Higher levels of HIV in the mom have greater transmission rates. And as we enhanced the potency of antiretroviral therapies, we've substantially decreased transmission from mom to infant. In that context, then, it's important for us to understand, ask the question and understand, does pregnancy alter how antiretrovirals are managed across the course of pregnancy? And what we find is that for some classes of drugs, it actually is. So for the nucleoside and nucleotide reverse transcriptase inhibitors, which are listed here, there is no change in pharmacodynamics across the course of pregnancy, at least where they've been evaluated. For the non-nucleoside reverse transcriptase inhibitors, there appears to be no change. But we do know for the protease inhibitors that there are substantial changes in plasma concentrations across the course of pregnancy, with green the levels post-partum and yellow the levels during pregnancy. So it's clear to preserve therapeutic efficacy and minimize infant acquisition of HIV, we need to change the way that we dose these drugs during pregnancy. So that's just an example of how we'd like to proceed. So we're trying to develop a program that includes characterization of health status, that is driven by a biological understanding, and that looks at changing health status as a function of what we're doing scientifically to improve both the health of individuals across the course of their lives, maximizing healthy trajectories and minimizing health disparities. And again, we believe that preconception health, health across the course of pregnancy, and in infancy are strong stimuli of health status of our population in the U.S. And we're doing it in a relatively narrow area by looking at strategies for improving pediatric and obstetric therapeutics. And again, I'd like to thank you all for listening to me. I'd like to thank the organizers for inviting us to begin to engage in a dialogue. And I'd like to just comment briefly at the end on two programs that we're doing jointly with Health Canada. Approximately 4 years ago, Michael Kramer came to the National Institutes of Health and sat down with myself, Dwayne Alexander, my director, Jermaine Buck, an epidemiologist, and we said, what are the two programs that the NIH and the Center for, I can't remember what the equivalent is, CIHR, the Canadian Institute for Health Research, can do together that would have the strongest impact on these areas of maternal and child health. And based on a series of discussions, we've initiated last year 2 courses between the U.S. and Canada that deal with reproductive, perinatal, and pediatric epidemiology, and that deal with obstetric therapeutics. This is the second year that both courses have been offered. They're both enthusiastically applied to by students from the U.S. and Canada, and I think it's just a really good underpinning of the kind of collaborative interaction that we should look to engage in much, much more. And thank you very much for your attention.